You're listening to Heart Conversations, an unscripted discussion on today's hottest topics in interventional cardiology, with your host, Dejan Milasinovic. This podcast is brought to you by PCR.
Hello, everyone. It is a great pleasure to welcome you again to another heart-to-heart conversation. This time, I will be joined by Nicole Karam, who is currently a voice from Beirut, a very well-known voice in the field which we are going to be talking about today, which is valvular interventions. Let me briefly remind you of the concept and the format of heart-to-heart conversations. We have an open discussion about hot topics in interventional cardiology, which is broadcasted live over several platforms. You can enjoy this discussion on LinkedIn simultaneously with X, YouTube, of course, PCR Online, and Facebook. If you have any comments, then you have to go to PCR Online and let us know about your opinions and questions, and we are very glad to address those. Now, Nicole, over to you. Very warm welcome, and thank you for joining us for this very exciting conversation.
Thanks, Dejan. Thank you for the invitation. Very nice to see you and to see you in Paris when I'm in Beirut.
It's all virtual, you know?
Yeah, I know. But I'm really in Beirut.
I know that. So let me introduce the topic to our viewers and listeners today. It is very important to know that this discussion will be available as a podcast as well. So anybody who wants to enjoy it afterwards as a podcast is very well welcome to do so. Today's discussion will be around the valvular interventions. And the question is, are we entering the new age? So before we get into specifics, I want to ask you, Nicole, are we entering the new age now of interventional cardiology, where valvular interventions will become a routine for interventional cardiologists?
Well, big question, but I guess we are already in. We have entered few years ago without even noticing it. Now it's more official with the guidelines that came out this year. But I guess we have been in the new age for a while. It depends on the valve also. Some valves, especially aortic, we are in the new age for a while. We have been in the new age for a while. For mitral, for tricuspid, things are following. But of course, today, being interventional and doing structural is like, it's the same job. I mean, it's everywhere. So yeah, we are in the new age.
So tell me, as an interventional cardiologist, do you focus on valvular interventions or do you perform coronary interventions as well? I think this is an important point before proceeding with further discussions. Who is doing these procedures? Are those interventionalists also doing coronary interventions or not?
Yeah, it's a big question, and it's something that is very important to discuss, especially when you go to our young fellows and our young colleagues who wants to train for structural. I guess I'm still doing coronary. I will keep on doing coronary because we cannot imagine treating structural disease if we are not able to treat a ostium of left main. If we happen to occlude it with a Tavi, we cannot be unable to treat a circumflex artery if we impinge it during a mitral procedure. So yeah, we should be both, I guess, at least for now. And yeah, we should start with training with coronary, learning how to puncture, how to navigate through the arteries before going to the structural.
Yeah, I would humbly agree. I think that at least a degree of knowledge and a degree of experience in coronary interventions might be currently a prerequisite for valvular interventions, but it's not the same around the world. So let us see. It's exciting to see how this develops. It might develop in another way as well, where you will have specialists in structural interventions. So let us then start with the first question, and that is the question of Tavi. So basically, are we now entering the new age of Tavi as well, as this is all expanding? So basically, now you may consider the new age limit, where 70 years is the new cutoff, at least for Europe, to think about Tavi rather than surgery. So how do you feel about this new age limit, and what evidence do you think is it behind? What does it stand on, this recommendation?
So yeah, this time it's not about us entering the new age, it's about a new age entering the guidelines. And we saw the 70 years old of cutoff entering the guidelines. It's still a little bit above what we have in the US with the 65, but I guess this is very if we look at the current data that we have, obviously it was time to decrease the cutoff age because we have improvement in the devices, more experience, less PVLs, less complications with our patients. We also have seen the efficacy of valve-in-valve procedures. So it made sense to decrease the age. You also see that today, even during surgery, we are putting more and more biological valves. So as long as you want to put a biological, then why not put it percutaneously? So it made sense to decrease the age. But if we go through the studies, we see that lots of those studies excluded patients below 70. And this is why it was a bit of caution that I find that according to me made sense to stay with patients above 70 years of age. So this is a new age, but totally it makes sense. The problem also with going with patients who are even below 70 is that the more we go for a lower age, the more we have a life expectancy. So how many valves are we going to make for our patients? And the other thing is that the lower we go in age, the more we see bicuspid patients coming in. And again, those patients we have still a little bit of debate on those.
When we think in terms of benefit for patients, we've seen in, let's say, independent trials like Dedicate, which was a German-run trial with different valve types with it, Tavi versus surgery. We could see an early benefit of Tavi in low-risk patients. Now, my question to you is, would you think that this early benefit of Tavi over surgery is the same regardless of the age? I mean, whether it's a 70-year-old or an 80-year-old, we should expect this early benefit, correct?
Yeah, we should expect it because the time to heal when you only had a puncture versus a real scar and a surgery is definitely going to be different. The pain is different. I mean, the daily life of the patient after the procedure is going to be different regardless of the age. Now, the question when we go below is, of course, the durability of those patients. And this is where the age is important. We have a lot of proven efficacy, and that because we might wonder whether this benefit we see initially is not going to last actually, and that in the next years with structural valve deterioration, we are going to see that as the surgery is taken over. But in reality, we've seen good results with safety of those and proven durability of those valves at 5 to 10 years. So maybe this difference is going to last. It's not only about feeling better after the procedure.
That's the main question because, in elderly patients, and if you ask me about the age of my patients that I perform Tavi on, it's closer to 80 than it is closer to 70, to be honest. So most of the patients I treat with Tavi it's 80-year-olds, where you really see this huge benefit of not going to open heart surgery in an 80-year-old. And my question is, if you have this early benefit in a 70-year-old, which should be roughly the same or at least similar, of course, then the question is what comes out of a 10 or 20-year-long follow-up that you expect in a 70-year-old, which is not the fact if you're treating someone who is 83. So what challenges do you see in terms of lifetime management with this new age limit?
Yeah, with this new age limit, the younger patients we take, the more we have to take into consideration the anatomy, the valve choice is very important. The positioning of the first valve. Technically, treating a younger patient is an even higher challenge. Even if we know that all those patients, we can treat them and get them out of the cath lab. The question is, how do we make sure that the next procedure is going to go well? So when we implant the first valve, we are already preparing when we are treating a 70-year-old, the second procedure. So we have to make sure that we chose the appropriate valve, that we didn't choose a very small valve in that patient. If we have to look at the coronary height. So it's very important to consider that the first procedure is only a first procedure. It's the one that precedes the upcoming one. So we are not working where the point is not to get the patient out alive. Most likely we will. The question is, how do we make sure that next time it's going to go well, since this is very important in those patients.
You just described the new age of valvular interventions. So in this new
Absolutely.
age, we're not thinking only about the first procedure. We're thinking about the next procedures to come. I would say this is the mentality we have with PCI. Now with PCI, when you perform coronary interventions, you're not thinking about getting the patient alive from the table. You're thinking about a long-term perspective of the patient. And this is why you would use more intravascular imaging, for example. So I think this is the new age maybe of interventions, of valvular interventions, where you now will have a priority to think about the potential next procedure in a 70-year-old. Now, that being said, the new ESC guidelines just released in September do have on two issues and updated recommendations, which I think, and I hope you would agree, do play a central role in the planning of lifetime management. One is bicuspid disease, and the second is coronary artery disease. May I then first ask you to comment on the challenges of treating bicuspid disease with a Tavi, and then we'll proceed with the coronary artery disease.
Sure. So for the bicuspid, it takes a little bit more experience to do those patients. As you know, those patients have most frequently calcified valves, and most of the times they are asymmetric calcifications. And we also have the elliptical size of the aspect of the valves, which makes it a little bit difficult to size those valves. I mean, it's straightforward when you are dealing with a regular patient, but with bicuspid, we have so many different techniques to select the appropriate size of the valve. And we still know that we are exposing ourselves to perivalvular leak, to the risk of aortic root injury, even to an increased mortality in some studies. And we've seen some diverging results of the studies according to the experience of the team. And I guess this is paramount. If we put the guidelines to everyone, I would say I totally find that it makes sense to only keep a 2B. This is what we have today in the guidelines for those patients for the bicuspid valves, because it's more challenging, more complications, and again, more difficult sizing and positioning. But if we are an experienced hand, and maybe this is what explains the discrepancy, if we are an experienced hands, then most likely we will have similar results. For now, keeping the caution of a 2B recommendation makes sense. And also, we shouldn't forget that those patients that were frequently excluded from initial trials. And here again, it's very difficult to say, I will choose the bicuspid valve and I give you that result. This is the percentage of benefit I will get. It's not really true for most of the studies that we've seen happening with Tavi. Of course.
Yeah, that's very important because an Ocean 2 trial basically showed in a subgroup analysis a difference in favor of surgery for bicuspid valves. And one of the reasons is the stroke rate, of course, which was higher for Tavi. So I think that what you said is very important. I think gaining more experience with bicuspid will be important. And I think that the guidelines recognize this, not really giving Tavi a strong recommendation over surgery. Only in those cases where surgery is not possible would Tavi emerge as a bicuspid, let's say, a solution. So I think that is an important point which we need to underscore, that for the time being, bicuspid remains a challenge and we may need to learn more. Of course, in experienced hands, it is different. But then again, as we are entering the new age, more and more centers will be performing Tavi, and it's important to know that bicuspid is a challenge.
Absolutely. So I totally agree with this 2B, with this caution that we keep on taking. And then maybe one thing that we didn't mention is frequently when you have the bicuspid patients, they have aortic disease also. And especially if you go to younger patients, if they have a dilated aorta and they also have the bicuspid valve, most likely we will go for a Bentall procedure for replacement of the ascending aorta. So this is another reason to give time to assess the feasibility and the risk of surgery before throwing yourselves into any bicuspid, especially if the experience of the center is still limited.
Okay, so tell me then, what is your approach to coronary artery disease, which is often concomitant with the aortic stenosis? How do you do it today?
Okay, how do I do it, or how am I supposed to do it? I guess what is sure is here again that we need to take into account the life expectancy of the patients, their symptoms, the height of the coronary, and the type of valve that we are using. There has been a lot of studies where they were discussing whether, for example, Notion 3 that compared conservative versus PCI, and Notion 3 had a real impact on the guidelines, because if they look at what is recommended today in those guidelines, it's more than 90% lesions in arteries with a diameters of 2.5 or more. This is a 2A. And more than 70% if it's proximal, but this is also for surgery. So notion 3 showed us actually that the higher incidence of endpoint came mainly from myocardial infarction and from unplanned PCI. This is funny because this is also what we see in most of chronic coronary artery disease studies. We see that those patients, actually the difference is going to play in terms of MI and unplanned PCI, and this is very intuitive. So today, how can we deal with those patients? I guess the guidelines also, again, make sense. Well, I mean, they're experts. I'm not here to judge. But I mean, obviously, this is exactly what we are doing in our daily practice. If we have those patients with severe proximal lesions, especially those patients with symptoms or patients with big vessels, it's very difficult to decide to look at those lesions and then turn away and just do the Tavi. Now, one thing that wasn't really decided in the guidelines is the timing of the procedure. They don't really specify whether we need to do it before or after. Doing the procedure after the Tavi will make it a bit complicated. Again, experience is key. If you are not used to going, especially depending on the type of valves you selected, if you have a high frame and you have to cross through it to go to the PCI, then maybe just go with the PCI earlier. If you are selecting a lower frame, then maybe there's no big difference. But here again, the life expectancy is important, and knowing that the patient has a coronary artery disease sometimes would push me to choose one valve or the other. It's not only about PCR or not. It's also about what valve should I implant, and what type of valve. And even though if you have experience with crossing through the Tavi and doing PCI through the Tavi, you have to keep in mind that your patient might have a myocardial infarction while traveling, I don't know where, and you might end up with an unexperienced hand. And this is something we need to keep in mind. It's not only about doing the initial procedure, it's again about lifetime and when will the patient need his other procedure and what kind of hospitals will he have nearby.
So a provocative question now for you. Is concomitant coronary artery disease a reason for you to consider surgery rather than percutaneous treatment?
Again, we have to look at the patient as a whole, as an entire person. It's not about that part or the other. If the patient is fully asymptomatic, it depends also on the complexity of the lesion and the possibility of complete rebus. If my patient has a left main and also an aortic stenosis, it doesn't make sense. I mean, it also depends, but here is something that would push further towards surgery. If it's a simple type A lesion where you are just going to do with a direct stenting, it's an easy type of lesion, then why not just go with PCI? And there has been a trial, the TCW trial that compared FFR guided PCI and Tavi versus Cabbage and Saver. And what you've seen is mainly a difference in death and bleeding, which is not, it's not
in favor of Tavi and PCI.
In favor of Tavi and PCI. So this shouldn't be an argument to say, okay, my patient has coronary disease, then I am going for surgery, because we only have this trial and the smaller one, but that was top. But this one was the real big trial, and it showed an advantage for Tavi. But here again, we have to make sure that we select the appropriate valve and we leave the room open for potential other procedures, why either it's restenosis or another disease, coronary artery disease, that will develop with time.
So thank you for that. Let me recap a bit. So this first section on Tavi. So basically, the new recommendations push the age limit down, favoring more percutaneous solutions, more Tavi than surgery in younger patients. But this is not a resolved question. This is not a resolved question on a case-by-case basis, because there will be patients who will go to surgery who are above 70 because of various reasons, like bicuspid disease or a very complex coronary artery disease, and so on. Then the second thing is that the valve type appears to matter. And you will then have to see, considering the lifetime management and the comorbidities, like, for example, coronary artery disease, if you do opt for a percutaneous treatment, which valve type you will choose, because it will make a difference. So I think those two issues will need to be debated further with, of course, new experience and, of course, the emerging trials in that space. That being said, let us go over to mitral. So my question to you is, given now that basically almost a routine use of mitral interventions in a specific subpopulation of patients with secondary mitral regurgitation and heart failure is recommended, are we now looking at something, a similar evolution like Tavi, that the mitral interventions will spread like that? Do you see that coming?
Well, I guess yes and no. If you look at mitral regurgitation is not a single disease. So if you look at the primary MR, the results are pretty good. Our daily experience is great. But if you look at the number of randomized trials published on Tavi to get us to this point, we don't have the same number of studies, of randomized studies done in the field of primary MR. We have the Everest 2, and then ever since we've been dealing with daily practice, we have few trials that try to address high risk and intermediate risk. We had the Meta HR, for example, in France, but those studies are not done yet. And this is why if you look at the guidelines for primary MR, the guidelines still tell us to go to surgery and to push towards repair when we can. Now, if we look at secondary MR, and here again, we need to distinguish, it's again not a single disease. We have atrial SMR, we have ventricular SMR. So for atrial SMR, again, not so many studies so far on this. The definition by itself, it's the first time that it makes it to the guidelines. But what we can see today is they put the surgery before the percutaneous treatment. Now, the field where definitely SMR treatment is becoming real routine is secondary ventricular mitral regurgitation. And here we see that today in the guidelines, they removed the part where we had to discuss whether surgery is feasible or not. And we have to go to intervention according to the possibility to the characteristics of the patient and the valve. It will be a 2B or it could be an A or a 2B. But anyway, in this case, it is a routine procedure.
Okay, so let me ask you this. In your experience, could you describe us a patient who will currently, from your experience, benefit from a mitral procedure?
Well, I guess the first consideration is the patient that has a good anatomical criteria. If you look, either we are talking about primary or secondary, as long as you know that you can go with a good result, and this is important in all the trials. Residual MR is an issue. Mitral stenosis a little bit less, but it's important also. So the anatomy is paramount. Now, if you look at the primary, so it's mainly the anatomic criteria. If you look at the secondary, the patients that benefit the most are actually the patients who had optimal medical treatment before, who are not left after the procedure. I mean, it's not like treating the disease and then moving around. It's about treating the patient as a step of his heart failure program. And then after the procedure, optimization of medical treatment and increase in the doses of medication is very important if we want those patients to really benefit from the procedure. And the third criteria that we need is early referral. And we can see today that we are moving forward to moderate SMR instead of going simply with severe SMR. And those patients do well. I mean, if we are going with severe, then we have to go with severe, but severe not with very diseased left ventricle, not very dilated ventricle, not with very severe pulmonary hypertension, right ventricular dysfunction. So it's all about choosing the appropriate patient and sending him early to the procedure if you want him to really benefit from it.
And I think you said a very important thing. You said that, those patients who you think will benefit are those who are well treated medically. So we should not forget that, the evidence is there for heart failure patients, and there are efficient heart failure therapists in terms of conservative management with medical therapy. So we should not forget that we as interventionalists are just one piece of the puzzle in treatment of those patients. And this is, I think, a bit different from what we can achieve with Tavi, because with Tavi, what we do may be a major thing, because it's a mechanistic problem in most of the patients. Of course, you will have heart failure patients there as well, and that's a whole new field maybe opening up in that space. But the weight of the procedure might be different when we speak about Tavi and about Mitral. So I think as interventionalists, we may be in need of adapting to that situation where there is an efficient medical therapy, like for coronary artery disease, and then trying to find patients who we can help with an intervention. And I guess that even the guidelines go in that direction because they are profiling the patient pretty exactly. I think those profile characteristics do overlap with the COAPT study, but the direction is that you need to choose the patient well before you apply the therapy, the interventional therapy.
Absolutely. And one important piece of the puzzle is that actually sometimes you are completely stuck with the medical treatment of heart failure because of low blood pressure, because of several limitations. And what we've seen in the studies is that after treating those patients with an edge-to-edge procedure or whatever, those patients will have a better hemodynamic, and we will be able to up-titrate, and we have to up-titrate. So we are simply just one player in the heart failure field, but it's not the end of the treatment for the patient.
So let me ask you then about the last frontier, and that is the tricuspid interventions. I mean, when you think, to me, this might be even the most exciting part, intellectually at least, when you think about those patients who come congested with ascites and just overloaded with volume, in whom you have severe tricuspid regurgitation, then basically medical therapy seems not to help there anymore. So the question is whether tricuspid interventions might be able to fill that gap in those patients. And there seem to be trials pointing to a possibility of improving at least the quality of life. If not in the longer term, and this was shown in the Triluminate, you could even reduce heart failure rehospitalizations, which is basically what the medical therapy does, effective medical therapy of heart failure. So how do you see the tricuspid interventions moving forward? And please tell us more about the different options, replacement and repair.
So I guess tricuspid regurgitation is a huge field actually, because most of those patients, if you look at them, we are treating 90% of patients, 95% of cases, we are actually dealing with patients with secondary TR. And those patients are very difficult to send to surgery. If the patient has an excellent LV valve, whether it is a previous mitral regurgitation or whatever, and the valves are functioning very well, it's very difficult to send them to surgery. Again, if it's only about a transvalvular lead, those patients need some care, and not having to send them to surgery might be a good option for those. So one thing that all the studies proved, I totally agree on what you said on the importance of the improvement of quality of life and also the heart failure hospitalization. But maybe the one main thing that we've seen with all the trials is the safety profile, especially of edge-to-edge. You see that actually you are giving your patient the opportunity to improve in terms of quality of life, but you are not really exposing it to a big risk. Now, here to answer your question regarding repair and replacement, we are not in the same scenario. If you are going with an edge-to-edge, we are going with no risk of pacemaker, almost no mortality, one patient per study. So it's a very safe procedure, and the improvement of TR is there if you actually select well your patients. So why not try it and improve the quality of life of the patients and his hospitalization? Maybe with longer follow-up, we will see also the difference in mortality. When it comes to replacement, I guess there will always be patients. There are patients that we are not able to treat with edge-to-edge. We are insisting on the importance of early referral, but whatever we do, we'll always find those patients that we cannot treat forever with edge-to-edge. And I guess we do need replacement devices. We have to have different options for our patients. We cannot imagine that it will be one magical tool and it will cure all our TRs.
That's an important message, I think, because TR may be a diversification of approaches, may need a diversification of approaches, as you said. So coming to an end, I would like to cite a provocative comment and a question from the chat box. It's our participant, Dr. Nabil Saleh, who asked whether in the future you think that interventions, meaning transcatheter interventions for valvular disease, will become an overall default, unlike surgery. Do you think that there will be more transcatheter interventions than surgery for valvular disease? I do know some European countries where currently transcatheter valvular aortic replacement, so Tavi, is more than surgery for the aortic valve. But do you think that overall, for all valves, this could happen?
I mean, why not? What we need to prove actually is the durability of the results that we are having. And this is something we are missing. All those procedures are pretty young, and we have to make sure that the results will remain here. There will always be complex cases where percutaneous treatment is not possible. We will always have endocarditis, where the idea of just treating the valve and keeping it in place is not a possibility. There will always be complex diseases with dilated aortic ascending aorta, where you want to treat also the aorta. Although we have seen devices and procedures where you actually treat both percutaneously. So I guess we still have a lot of fun to have in this field, but at some point it might become the default procedure.
I think this was well said. So we need to be cautious, and we need to look at each patient, in each patient's benefit, and take all of these options into consideration. I think that surgery will remain a very, very valid option for many of our patients for quite some time. Thank you very much, Nicole. It was really a pleasure. And thank you to all of you who were there with us.
Thank you, Dejan.
Thank you for listening to this heart-to-heart conversation. Find out more about upcoming dates and replays of recent conversations on pcronline.com.